Thank you very much. First of all, I would like to thank the organizers for inviting me to present on TB. And we've been discussing TB in this workshop, particularly for the last 2 years. And I was discussing with Ruben Granich, what should I present? Because the benefit of treatment as prevention for TB is no-brainer. What am I going to say? Even to be honest, I wasn't sure that I should come, but he basically insisted that probably it's better if we share the programmatic aspect of dealing with TB HIV in the context of treatment as prevention, with ultimate goal of bringing programmatic implementation of TASP. So in my presentation, what I'm going to do is really to highlight the critical issues that actually impede the implementation of this no-brainer issue. Before I start, just to give you a background, this is a result of a meta-analysis that we did in 2012 that summarizes all the studies, both observational and randomized, that actually looked into the individual level impact of earlier ART or ART in general for people living with HIV in preventing TB. So as you can see, the stratification was between less than 200, between 200 and 350, and more than 350. So in all the strata of CD4 count, you can see that there is huge benefit when it was like a 84% protection if it is less than 200. 66% when it is between 200, 350, and around 57% when it is more than 500. And similarly, this is a recent publication that was also mentioned by the previous speaker that actually showed earlier ART has significant TB reduction benefit as it was shown in this H1005 randomized trial, which actually was also included in the meta-analysis slide I showed you earlier. When we also look the population level impact, this is a study that was published from South Africa, from one of the townships in Cape Town, that actually showed the population level of impact of ART expansion. So the graph here actually showed the TB notification rate starting from early 90s until 2008, and the one below shows the ART coverage. So as you can see, with increased ART coverage, the TB notification rate in that community also reduces. Another publication, again, that shows the population level impact of expanded ART was from Malawi. As you can see in red, the new TB cases, TB case notification. This is nationwide data, and as ART increases. Similarly, this is a program data, national data from Botswana, that again shows with increased ART, the reduction of TB notification in yellow triangles, and also days, overall adult mortality days. So there is no question increased ART is actually addressing TB both at individual and population level. In addition to that, when we looked the use of antiretroviral with isoniazid preventive therapy, there are studies that actually showed if we use ART with IPT, we can eventually achieve virtual elimination of TB. As you can see from a study in Botswana that was published in the Lancet 2007, among skin test positives, using IPT and ART actually resulted in 97% protection from TB. So all in all, through the progress of implementation of TB HIV activities over the last decade, there is a global trend of reduced TB HIV related diseases, and it looks like we may also achieve the target of having 50% reduction of TB mortality both in Africa and globally by 2015. However, we still have 320 people living with HIV dying of TB. This is equivalent to 1 out of 4 people living with HIV are dying from TB. So why is this happening, and why is the underestimated the benefits of treatment as prevention or earlier ART or expanded coverage of ART, as you want to define it, is underestimated. So the first thing is we are not reaching all those people living with HIV we estimate to exist. We estimate every year there are 1.1 million people living with HIV who are developing TB every year, and we were able to reach only half of them in 2012. And as you can see, most of these estimated people are living in Africa, 80% of them, where there is only 53% of those who were received care in 2012. So the percentage also, as you can see 68%, but Europe only constitute for an insignificant portion of the estimated number of cases. So in general, we are not reaching those who are also developing TB every year. Similarly, when we really look in the same statistics from the top 10 high TB and HIV burden countries, which contribute for 70% of the global burden, Kenya is the one that was able to detect or to provide care for 80% of the estimated people living with HIV who developed TB in 2012, and the statistics goes into 34 in Mozambique and India. But as you can see, majority, they are not even detecting those who develop active TB. And when we looked, WHO recommends antiretroviral treatment for those people who develop TB, regardless of CD4 count. And this shows the coverage of ART for TB patients in 2011. As you can see, still not 100%. Ideally, we expect 100% coverage, but in most countries, in high burden countries, this is not the reality yet. And one other critical issue is countries are slow in uptaking policies, and this is a graph slide that shows the uptake of the WHO recommendation of ART for TB patients regardless of CD4 count in 2010, which actually shows there are still countries in the red zone. We also know that there are more decentralized TB facilities than ART. ART is still decentralized and they are too few. This also brings access issue. Another neglected area is convergence of TB, HIV, and hepatitis and drug use. And these are studies reported that actually showing among factors as drug use is significantly associated with developing TB in people living with HIV, and also the convergence of hepatitis B, C, and HIV in Argentinian TB patients. This is also a recent study that reported mortality among almost 600 people living with HIV from 5 Eastern European countries, Belarus, Latvia, Romania, Russia, and Ukraine, that actually showed the cases were followed for 4 years, and it showed up almost 70% of those people living with HIV with MDR-TB died in the first 4 years of follow-up, and about 40%. And this is incredibly alerting data. Again, childhood TB is neglected. This is a recent study that was also published from Côte d'Ivoire, which actually looked into 2,000 children with HIV, which found within the first 90 days of follow-up of ART initiation, 6% who were not supposed to have TB at initiation developed TB, and also the incidence rate of TB was almost 3 times higher in children than compared to the general population. Another important point is program managers are not collaborating at country level, and this is a famous quote from a former Ugandan TB manager who said, if a virus and a bacteria can work together, why don't we? And similarly, program managers from Cambodia, the HIV and TB program managers, they said the lion and the tiger never talk to each other. And unfortunately, we have to bring the lion and the tiger to talk to each other to attend a meeting in Geneva, which actually helped them to start planning and now see what's the successful TB-HIV implementation in Cambodia. There is also fear of a big fish swallowing a small fish at a country level. We don't know which one is big and which one is small. And similarly, there is an effective management. Both programs are oftentimes functioning in a very vertical way, probably with a slight pipe type link up or totally independent. And there is also a lot of inadequate technical capacity and power imbalance between programs. So that's why now the Global Fund is encouraging joint TB-HIV programming to push for the programs to interact to each other and also develop a single proposal for the new funding model. And the new funding model is much more complicated, as you can see from this slide, where now it's not following writing a very nice round-based proposal, but it's more of country allocation, predetermined country allocation of funding and country dialogue. And this is just to show you how the current Global Fund country allocations are done in a very complex 8-step procedure, where you can have your specific TB, HIV, or malaria resource allocations. And as you can see here, actually HIV got the greater proportion of all 2014-2016 Global Fund allocation, almost 50%, which I think is equivalent to 7 billion compared to the others. And also, when you really look into the guidance from Global Fund, the information note on strategic investment actually identifies antiretroviral therapy for people living with HIV, including for preventing HIV transmission, as one of the cost-effective strategic investment, high-impact interventions. So, in conclusion, TASP for TB is now established. As I said, it's a no-brainer for both individual and population level. However, implementing TASP or scaling up antiretroviral treatment cannot be done in isolation before addressing concerns of country programs. Country programs have their own program prioritization. Country programs are detected by availability of resources. And also, more importantly, is the delivery system should be effective, and also it depends on programmatic realities. And in order to address the TASP advocacy agenda, as I understand, the definition of TASP is also beyond, it should be beyond test and treat. It's about preventing transmission, it's about preventing death and also disease. And that agenda should actually embrace program managers, because at the end of the day, they are the ones who are implementing these interventions. And engaging those program managers, I believe, will help to step up treatment scale up in a broader context. Thank you very much.